The floor is yours.
Okay, thank you very much, Pachi. Hello, dear friends, dear colleagues. Thank you very much to be here. I hope your family and you are safe in this pandemic time. Welcome to our second webinar about wide awake and minimally invasive surgery for nerve entrapments in upper extremity. It is 7 p.m. in Paris and Stockholm and 1 p.m. at Montreal. And we are more than 366 people from 62 countries. So thank you very much to be with us. And we are here to listen to Elisabet and Jean-Paul. So thank you guys to be here. Thank you very much.
Thank you for having us.
We are here for 1 hour. And we like to talk about the Walant surgery. Walant, you know, that means wide awake, local anesthesia, and no tourniquet. And it's developed by Don Lalonde. I would like to thank him for his teaching. And we have a big thank you to Don. So Elisabet, thank you very much to be here. And you will talk about wide awake and minimally invasive surgery for radial nerve and Lacertus syndrome. Thank you, Elisabet. Thank you very much.
Thank you, Thomas, and thank you to everyone for joining us here tonight. And I am so excited to be online again. And I am going to show you today what I do for wide awake surgery when it comes to radial tunnel and the Lacertus syndrome. Both of them are two of my absolute favorite surgeries. So I'm hoping you're all seeing my screen right now. So for wide awake surgery, let me start by discussing the radial tunnel, and then I'll finish up with the Lacertus release. The radial tunnel syndrome is a syndrome that is actually quite common in my practice. And the radial tunnel syndrome is most often found in conjunction with or misdiagnosed as a lateral epicondylitis. So all of your tennis elbow patients, remember to think about radial tunnel syndrome. In fact, when we did a retrospective study between 2002 and 2008, we found that 95% of the patients that we treated for radial tunnel syndrome had been diagnosed as lateral epicondylitis, and every single one of them had failed conservative treatment. Now, all of you who are therapists and know that how passionate I am about physical therapy and hand therapy, when it comes to the radial tunnel syndrome, you will actually find that physiotherapy will worsen symptoms. So if you have a patient that not has a lateral epicondylitis, but has a radial tunnel, they will get worse from doing lateral epicondylitis exercises. But the really key symptom to listen for in these patients is when they no longer have pain at activity, which is typical for the tennis elbow, but they have pain at rest, and they have pain at night. So they're gonna be saying, oh, I wake up at night and I have this dull ache and pain in my forearm. That's typical for the radial tunnel. As with any peripheral nerve compression, like we talked about in our first webinar, the clinical triad of peripheral nerve symptoms is muscle testing, the scratch test, and pain upon compression. I'll go through that again. So for the radial tunnel syndrome, EMG or nerve conduction studies is really quite useless. The radial tunnel syndrome only shows up between 15 to 30% of patients, and so clinical diagnosis is the way to go. The clinical diagnosis when it comes to the muscle testing for radial tunnel syndrome is weakness in the ECU, in the extensor carpi ulnaris. Here you have a patient who had a chronic lateral epicondylitis, but he actually had a radial tunnel syndrome. So arm completely extended, hand ulnarly deviated, and he is trying to resist as much as he can, but he cannot. So you can see that ECU breaking right there. Whereas on his left side, where he's got no radial tunnel syndrome, I can't break that wrist. So testing for complete ulnar deviation in the hand and that ECU strength. The next thing is the scratch collapse test. Now, for the radial tunnel, you can either scratch or you can push over the nerve and then do the scratch collapse test. As many of you know, the scratch collapse test was first described by Susan McKinnon and co-workers, where scratching over the area of a nerve compression will cause a temporary loss in voluntary muscle contraction. So you see this guy in the video, you see that huge muscles that he's got in his upper arm. Well, this is a carpenter. He's right-handed. He's been working a lot with tools, and so he has developed a radial tunnel syndrome. So what I'm doing is I'm pushing. He's trying to resist in rotation of the shoulder. I'm scratching over the arcade of Froese, and I'm pushing, and he cannot resist that. So despite that complete upper body strength that he has, that scratch collapse test is quite positive. So scratching, and you see that arm break. The last step is pain over the arcade of Froese. And finding the arcade, you palpate the lateral epicondyle, you go 3 fingers distal to the lateral epicondyle, and that is where the arcade of Froese is. And all radial tunnel syndrome patients really have a lot of pain over the arcade of Froese. When I do the Walant dorsal approach for radial tunnel syndrome, I really select my patients because this is a nerve that is quite deeply located, and so you cannot pick any patient for this. You have to actually select patients that you know strong or very nervous. The radial tunnel release is going to be difficult for them. What you want to do is infiltrate 20 to 30 cc's of lidocaine with epinephrine over the dorsal area. So you will see that little zigzag line in the picture. That's my incision. And then I infiltrate around that. And this is what it looks like when I've done that. You see that blanching of the skin, which is typical of the epinephrine effect. In addition, I place 10 cc's of lidocaine with epinephrine over the volar aspect of the arcade of Froese. And this is because you have to go all the way through the forearm pretty much to reach that posterior interosseous nerve. So this is what the radial tunnel syndrome Walant dorsal approach is like in my practice. You will see a little cross right there. That is where I have palpated the maximum point of tenderness, usually 3 fingers distal to the lateral epicondyle. I perform an oblique skin incision. So the lateral epicondyle is up here, the hand is down here. That's the point of maximum tenderness. And then just about a 4 centimeter incision. Blunt dissection down to the forearm extensor fascia. And what's important to note is once you get through that subcutaneous tissue, you will usually find a sensory nerve branch. And so you see that sensory nerve right there, extremely important to identify that nerve and retract it so you don't get a painful neuroma. Once you've located that nerve, you're down to the forearm extensor fascia. And so you open that fascia. And once you've opened the fascia, you can start looking at the extensor muscles. And so what you will notice is you have a muscle right there that has a rather thin muscle belly. That's the muscle belly of the ECRL. Whereas down here, you have a muscle belly that is more rounded and full. That's the muscle belly of the ECRB. And that's the space where you want to go down. So between the ECRL and the ECRB. So I do a little dissection with my scissors, but once I've gone through the fascia, I use my finger. Because you will find a little clavage, a little space right between the ECRB and the ECRL, and it's actually easier to gently use your finger to get all the way down. And once you've gone all the way down past the ECRL and the ECRB, you are right at the arcade of Froese. Once you've done this particular point, this is when you're going to want to have a little extra lidocaine with epinephrine. Because now you're getting all the way down to the arcade of Froese. And at this point, just sort of infiltrate that lidocaine with epinephrine, just sort of let it pool over the arcade of Froese to make sure that the patient doesn't have a lot of pain as you're getting ready to retract the muscle bellies. So what we've done now is we've put our retractors down and we've retracted the muscles. And so we have the ECRL right here, and we have the ECRB, and you see those retractors are quite deep. So it's a deep space that we're going into. And what you will find as soon as you get down there is the first nerve that you will see is the sensory antebrachial cutaneous nerve of the radial nerve. And so if you have difficulty finding the posterior interosseous nerve, you can always find the sensory branch. and then you follow that in a proximal direction to the bifurcation, and then you can trace the posterior interosseous nerve in a distal direction, and that will bring you straight down to the edge of the supinator. In quite a few patients, you will find that this first little muscle belly that you see right there, that's actually the lateral edge of the ECRB. And so sometimes you might have to open that, and that will get you down to the supinator edge. Of course, the arcade of Froese is the proximal supinator edge, and so you're going to want to divide that about 1.5 to 2 centimeters. Once you've gone through the proximal supinator edge, you've released the arcade of Froese, and when you've done that, you can once and then again do muscle testing. And what you will find is that the ECU power is back on the table. And let's see if we have sound. Can you hear this? Do it again. Excellent. I hope you heard what that patient said, because he said, I have power. And it's a wonderful feeling. It's like any Walant nerve release that you do. It's just the best once it's done and that power is back on the table. So when we, in our retrospective study between 2004 and 2008, we did 45 radial tunnel releases. We used RIT score to determine good to excellent, moderate, or poor results. The follow-up was 6 months, and we found that 88% of our patients had a good to excellent score. Between 2012 and 2013, we followed 45 radial tunnel patients that were released, and 29 patients completed both the pre and the post-operative quick dash. And what you will see is that the quick and the work dash was quite high pre-operatively, 40 to 50, and post-op down to 10 to 13, which is a very statistical significant difference. So don't be afraid to do your radial tunnel releases. Always remember to look for radial tunnel syndrome in any patient complaining of lateral elbow or forearm pain. So let's move on to the Lacertus syndrome. The Lacertus syndrome is like carpal tunnel syndrome, but for the elbow. In the wrist, you have a carpal ligament, and the carpal ligament is a fibrous band compressing the median nerve at the wrist. Well, at the elbow, you have the Lacertus fibrosus. The Lacertus is a fibrous band compressing the median nerve at the elbow. Once again, we're using the clinical triad of nerve diagnostics. We're using muscle testing, the scratch collapse test, and pain under the Lacertus. And as you will see in this patient right there, the Lacertus edge shown with the yellow arrow is very, very prominent. So why is the weakness found in the FCR, the FPL, and the FDP2? Well, if you look at the level of the Lacertus fibrosis and you do a transection of a median nerve at that level, you will find that the most superficial axons right there are the axons to the FCR, the FPL, and the FDP2. Contrarily, if you have a carpal tunnel syndrome, the most superficial axons are the sensory nerve fibers, in particular to the middle finger. And I'm just going to pause this for a second, because I'm sure quite a few of the people here tonight recognize this man. And this is, of course, Professor Don Lalonde. And I'm so grateful to Dr. Lalonde for teaching me about Walant, because it has forever changed my practice. Now, this is Dr. Lalonde, and this was quite a few years ago. And Dr. Lalonde told me that he had gone through not one, but 2 carpal tunnel surgeries, and he still had not gotten better. He still had median nerve symptoms affecting the function in his left hand. And this is his pre-operative clinical diagnostics. After you've found the weakness in the median innervated muscles, you want to test for pain upon pressure at the edge of the Lacertus and the scratch collapse test. This is what the scratch collapse test looks like at the elbow. So you scratch over the level of the Lacertus, scratch on the other side, and they can't resist. And the scratch collapse test is by far my absolute favorite test. It is just amazing because the response you get from your patients, you never know what it's going to be. It might be a laugh, it might be, oh, what did you do? Are you a magician? But it's just wonderful. So if you don't use it in your clinical practice, please go home and try and practice and use it. For the Walant, for the Lacertus release, this is by far the best operation to do in Walant, in my opinion, because it's so easy to do. It's never painful for the patient, and the result is just fantastic and immediate. So what you do is you perform an infiltration anesthesia on the ulnar-volar aspect of the elbow crease. In a slender woman, I will usually use about 20 cc's. In a man, I will use 30 cc's. And this is what the surgery looks like. You perform a small transverse skin incision on the ulnar-volar aspect, and you keep the incision right at the elbow crease because that gives you the most aesthetically pleasing result afterwards.
Use bipolar cautery as necessary. The first landmark defines the fascia over top the pronator teres muscle. It is bluntly dissected, both superficial and deep. And this is the clear, shiny layer you can see here. Using blunt scissors, this layer is cut so that the fascia of the biceps aponeurosis can be visualized underneath. Gently cutting and spreading. Here in this photo, the white thick layer of the biceps aponeurosis can be visualized and is carefully dissected both superficially and deep before cutting, as the median nerve is up.
I'm sorry, that was cut short. Let me see if I can get that longer. Okay, so what we did right there is the bicipital aponeurosis, or the Lacertus fibrosis, as you saw, was that white shiny layer. And once you've gone through that, you cut that white shiny layer completely, the Lacertus fibrosis. It's very easy to see. And once you've cut it completely, you will test the strength in the FPL and the FDP2, and you will see that the power is back on the table. I'm sorry for that video being cut short. This is, again, a video of Dr. Don Lalonde after we've done his Walant release of his Lacertus syndrome. And for anyone who is interested in this, you can find a more complete video both on using Walant, doing the surgery, and the pre and post-operative testing on ViewMedi. And so you see that link right up there. So this is Dr. Lalonde immediately post-operatively. So right after surgery, the power is back in the FPL, the FDP2, and the FCR. So we did a prospective study on Lacertus syndrome. Between 2011 and 2013, we operated on 119 patients. 70 of these completed both the pre and the post-operative dash scores. You found that pre-operatively, we had quick and work dash around 40, and post-op between 10 to 13. So once again, a very statistically significant result. So I want you all to remember to look for Lacertus syndrome in patients that have carpal tunnel syndrome. Any patient with carpal tunnel syndrome, look for the Lacertus. Or if you have a patient that has gone through a carpal tunnel release and they haven't gotten better, look for the Lacertus syndrome. If you have a patient that complains of loss of dexterity and loss of endurance, a patient that comes to you and says, you know, I just get so tired in my hand when I'm working, I have to take breaks all the time, but I don't have any numbness. Think of Lacertus syndrome. Think of Lacertus syndrome in any work that entails a pronated forearm and repetitive finger motions. So you will have a musician, you will have computer workers, surgeons, lab techs, dentists, and athletes. For instance, like here, and a professional mountain biker who got a Lacertus syndrome. Think of Lacertus syndrome in patients who have a negative EMG or a negative nerve conduction study, but they have obvious hand pain or hand dysfunction. So I want to close this off by showing a picture of this person. And this is my dad, Professor Carl-Göran Hagert. He was one of the pioneers of hand surgery at the 2019 IFSSH. He taught me everything I know about Lacertus syndrome and radial tunnel syndrome, and I'm forever grateful. He's 87 years old, and he's still going strong. So go, Dad, I love you so much. Thank you.
Thank you very much, Elisabet. Yes, thank you very much. And maybe we have a few questions. And there is one question of Bernard Lallemand from Dubai. And it was a question about the radial nerve. And he asked, during your surgery, when you open only the fascia of the superficial belly of the supinator, and what about the fascia of the ECRB?
Excellent question. Yes. So the fascia of the ECRB is usually opened as well. It depends on how lateral that fascia is. So quite often, I will open the fascia and the hard edge of the ECRB, and then open the supinator edge. So excellent question. Thank you.
Okay, so you start by the ECRB, and after.
Yes.
Okay, so you open it.
So you will usually find the ECRB first, and then you open that. And then you retract the ECRB, and that will bring you down to the supinator.
Okay, thank you. And for the Lacertus release, question of Fadi Bouri, do you look for compression more deeply at the level of the FDS? I heard you put sometimes a finger into the score.
I always do, and that I'm so sorry the video was cut short, but once you've released the Lacertus fibrosis, I put my finger into the space right over the median nerve, and I slide it all the way down to the superficial arcade.
Yes.
And that is where you can have a compression as well. And then if you're doing it wide awake, you can ask the patient to move their fingers, and you will actually feel if your finger is compressed in there, if it's tight or not. And if it is, you can make an extra little incision, just about 2 or 3 centimeters distal to the Lacertus incision, and release that superficial edge right there. In all of my Lacertus cases, I've done that 3 times.
3 times in 200 cases or 300 cases?
I'd say 600.
Okay, okay, so it's very rare. Okay.
Yeah.
And do you perform both Lacertus syndrome and ulnar nerve compression at the elbow? Is it possible to make a huge Walant injection for ulnar nerve and median nerve at the elbow?
Yes, no problem at all, because then you can use either 20/20 for the Lacertus and the ulnar nerve, or you can dilute to get a higher volume. So you sometimes find the Lacertus and the ulnar nerve combined. It's more, it's usually found if you have a Lacertus edge that is really, really tight. Sometimes you can see in a patient that they actually have almost like a little indentation in the forearm because the Lacertus is so tight. So Jean-Paul is showing us right there. So you see that indentation that can actually cause a combined median and ulnar nerve compression at the elbow, and both are from the Lacertus. But I must say it's more common to find Lacertus and radial tunnel at the same time, because if you have a Lacertus syndrome and you get weakness in your pinch, what you automatically start doing is hyperextending your wrist to get a tenodesis effect.
Okay.
Then you start overloading your ECRB, getting an epicondylitis and a tight ECRB, and that will push down on your radial tunnel. And so you will get a radial tunnel syndrome at the same time. So I almost always in my radial tunnel patients, I will do a Lacertus release as well.
Okay, thank you very much. We have to continue the lecture with Jean-Paul. Thank you very much, Elisabet. And Jean-Paul.
Thank you for great questions.
Okay, thank you, Jean-Paul. Thank you very much to be here. Jean-Paul Brutus is come from Montreal, Canada, and he will talk about less invasive surgery for ulnar nerve entrapment at the elbow, under Walant, of course. So thank you, Jean-Paul, to be here, and let's start. Maybe you have you're on mute.
Okay, can you hear me?
Yes, welcome, Jean-Paul.
Okay. Thank you, Elisabet. Thank you, Thomas. Beautiful talk from Stockholm. So I'm going to do my best here from Montreal. So hello, everybody from North America. So this talk will be about Walant surgery for ulnar nerve entrapment at the elbow, also known as cubital tunnel syndrome. And just a little reminder, the C8 and T1 cervical roots come out and they coalesce to form the medial cord of the brachial plexus. And then that sends off a contingent of fibers to form the median nerve and mostly become the ulnar nerve in the anterior compartment of the arm. Then the ulnar nerve travels with the brachial artery and then needs to go to the back of the arm by going through the medial intramuscular septum, and then that's where it joins the posterior compartment. And then, as you can see on this image, there's another structure under which the ulnar nerve tends to travel, which is the arcade of Struthers, which is some sort of a fibrotic epineuritic expansion coming from the medial head of the triceps and going to the intramuscular septum. This is the schematic representation of what's going on in the elbow area. You can see the ulnar nerve going through the arcade, posterior to the intramuscular septum. Then the nerve travels in a groove between the olecranon and the medial epicondyle in the cubital tunnel. And then it continues and enters the flexocarpi ulnaris. This is just to show you that there's a lot of variations that exist around the Struthers arcade, for example. It can be short and thick, as on the image on the left, but it can also be longer and flimsy in the middle. And so there's a lot of controversy and a lot of variation around this Struthers arcade. And one of them is the name. Apparently, there's no evidence in the literature that Struthers actually described that arcade and that he even knew about it. It was first described in 1973 in a paper that attributed this arcade to Struthers, but there's no evidence that he even knew about it. So I thought that was interesting. On the right side of the screen, you'll see the ulnar nerve going right through the intramuscular septum, going from the anterior compartment of the arm to the posterior compartment of the arm, just proximal to the arcade of Struthers. So I think you can see that quite well here. Then this is another beautiful image showing you the ulnar nerve where the stars are. And then in front of it, you see this thick structure that is being elevated. That's the septum. And then posterior to the nerve, you see the anterior border of the triceps muscle. It's important because when you do a surgery, I always look for the anterior border of the triceps to identify the ulnar nerve. So we'll get back to that in a second. So after that, the nerve enters what's called the cubital tunnel, which is basically formed by the floor of the tunnel, which is the elbow joint and the capsule. The walls are the olecranon and the medial epicondyle. And the roof is that cubital retinaculum, or also called Osborne's ligament. Sometimes you will find a muscle in there called the anconeus epitrochlearis, and you can find a muscle in there in about almost 25 to 30% of patients. So just something to be aware of. Sometimes you have a muscle in there, sometimes you don't. So this is a posterior view of the elbow, showing you the ulnar nerve traveling inside the cubital tunnel. You can see this triangular structure over here, which is the Osborne's ligament, and then the two heads of the flexocarpi ulnaris. So of course, the ulnar nerve will send a branch to the joint itself, and then it will power the FCU, the FDP, and then it will send some branches, sensory branches to dorsal hand, and of course continue to travel to enter Guillaume's canal and innervate the hand. This is a nice image showing you the ulnar nerve entering the flexor carpi ulnaris. You can see the FCU has been split open, and you can see that there's multiple motor branches to the FCU, and then you can see the nerve that dives deep to this structure here, which is the deeper fascia of the FCU. Then the nerve travels with the ulnar nerve, with the ulna down to in the direction of the Guillaume's canal. You have to know the anatomy, but you also should remember that there's a lot of variations in the anatomy. For example, here, it is traditionally known that the dorsal branch of the ulnar nerve comes off about 6 centimeters proximal to the styloid of the ulna. But in this case, you can see that the branch originates in the proximal 1/3 of the forearm. So of course that may change things when you examine people, but you just have to keep that in mind. You have to know the anatomy, but remember that there's variations. So what happens to the ligament, the Osborne's ligament, when the elbow is bent beyond 45 degrees to 90 and 135 degrees, is that the ligament becomes more taut and it constricts the canal. So the volume inside the canal decreases. The pressure increases and the nerve is elongated, and this is why you end up having problems with the ulnar nerve. And this will cause typical symptoms that you know very well, like numbness, pins and needles in the ulnar nerve distribution, with muscle weakness or wasting and these things. This is a cross section of the ulnar nerve at the elbow, and you can see in blue the sensory fibers, and in red, the motor fibers. So initially, the early symptoms are sensory symptoms primarily. Motor symptoms come later or with more severe compression of the nerve, except for the adductor pollicis, which fibers, or that's innervated by fibers that are more peripheral. So you should always think of looking for weakness in that specific muscle. So you know about the symptoms. Dropping objects, weakness, numbness, pins and needle, trouble writing. And then people would describe their hands as smaller or looking older or more bony because of muscle wasting. Clinical examination, of course, you start with a sensory examination. You can use Samys-Winstein's ligament. You can use 2-point discrimination, vibration, touch, anything you want. And then you have to do a motor examination, and that's where I'm going to spend a little more time. For example, here on the left, you'll see what's called Wartenberg's sign. That is a difficulty in adducting the small finger, which is caused by weakness in the intrinsics. And of course, a positive Froment sign, where the patient has a difficulty adducting his thumb and has to use the flexor pollicis longus instead of the adductor, which is innervated by the median nerve rather than the ulnar nerve. So something that I'm sure you know, and that's very useful. There are provocative maneuvers that are very useful for the cubital tunnel syndrome. For example, bending the elbow beyond 135 degrees and combining that with an extension of the wrist, compressing the nerve in the cubital tunnel, for example, or tapping the nerve, which will cause a tunnel sign. The sensory or scratch collapse test, which is also one of my favorites, and I like the cold spray, as I mentioned before. So here's a patient who came for surgery on the cubital, for right cubital tunnel syndrome, and you can see I'm testing his the power in his right arm after scratching him, and you can see positive scratch collapse test. Now the strength is back, and now I'm going to stimulate his left side, and he's strong there, no problem. This is Guillaume's canal, no problem. Cubital tunnel, right side, the arm breaks. Very spectacular, very easy to do, and very convincing for the patient. This here is testing the power in his FDP 5. So I start with the index finger. There's a lot of power there. And there's zero power here. As you can see, we're comparing to the healthy side. Very strong on the index finger, and he's strong on that side. the power and this now is testing the FCU, flexor carpionaris, which is also going to be weak, as you can see. So bent wrist, ulnarly deviate, and I'm going to try to oppose that, which is pretty easy in this tall guy on the right side, and I'm doing the same thing on the left side, and he has power. This is what his hand looks like. So you can see this typical claw-like deformity with imbalance between the intrinsics and the extrinsics, causing this hyperextension of the MCP joints and flexion of the PIP joints with an extension lag, muscle wasting, which is pretty typical. Always keep in mind that the problem can also be a root problem. So think C8, T1, always to have in the back of your mind. I'm going to agree with Elisabet when she was talking about the nerve conduction study. It can be useful if you have it, but I don't think it's essential in diagnosing cubital tunnel syndrome because often it will be negative or not necessarily reliable. What you're looking for is a reduction in amplitude of the CMAP, increased latency and velocity. One of the challenges that people who do EMGs have is that they don't really know where the nerve is because there's a lot of variation. So they don't know where the probes or the electrodes are. So, and that can change the distances, therefore change the velocity that is measured. But in general, you're looking for a decrease in velocity of about 10 meters per second below the elbow compared to above the elbow, or a velocity of less than 50 meters per second. I don't prescribe it for cubital tunnel syndrome. If it's available, I have it, great. If it's not, I don't need it, particularly if it's typical. I prefer a thorough examination, as you've seen, and just remember that it's not very sensitive, and in 20% of cases it can be negative. I like ultrasound. It's quick, it's easy, and it's quite demonstrative. You will see the epineurium and the perineum showing, and you'll have a honeycomb appearance of the nerve. In times of compression, well, then the honeycomb appearance tends to disappear. This is a beautiful image that shows you that the honeycomb appearance has disappeared. And you can also look for subluxation of the nerve. You can see the olecranon very well, the medial condyle, and all these nice structures. This is a long axis view that shows you a dilated nerve just proximal to the compression site. You can even see hypervascularity of the nerve if you use Doppler. An MRI is not very useful to diagnose cubital tunnel syndrome, but if you have one, it will basically show hyperintensity of the nerve. You can see some hyperintense signal in the muscles that are denervated, but it's definitely not something that you should order for a simple cubital tunnel syndrome. You know about conservative treatment, you know rehabilitation, anti-inflammatory medication, avoiding flexion, avoiding irritating the nerve, night splinting, preventing flexion beyond 45 degrees of the elbow. Cortisone injections do not seem to be effective to treat the symptoms associated with cubital tunnel syndrome. So then it's time to move on to surgery. And there's multiple approaches, including simple decompression of the nerve, which can be done in a standard manner or with a minimal in situ incision or endoscopically. And you can also choose a much more aggressive surgery like medial epicondylectomy or transposition, which can be done subcutaneously, intramuscularly, or submuscularly. My personal favorite is a minimal incision in situ decompression under Walant, which is done much like the wide awake procedures that Elisabet has described for Lacertus or for radial tunnel syndrome. You don't need a tourniquet. You just have to wait about 20 to 30 minutes after infiltrating the area with a mix of lidocaine and saline. The patient can be positioned supine with the elbow flexed and propped up, which is what I do, but it can also be done with the patient lying on the side or even prone. This is something I use to minimize discomfort associated with the injection. I use a vibration device that will cause noise to distract the brain while I'm injecting, and the patient barely feels the injection. They like it a lot. So these are the landmarks. So on the right side of the screen, you'll see the ulnar nerve right in front of the anterior aspect of the tricep. So that's what I usually look for as soon as I've incised the skin and retracted the sensory branches. This is Osborne's ligament. You can see on the left image, I usually go from proximal to distal rather than distal to proximal like it's shown on this screen. This is not one of my pictures. On the right side, you can see the nerve after it's been decompressed. Make sure proximally you make certain that you have released Struther's arcade and the intramuscular septum. You can do that with your small finger. I call that the pinky test. And distally, you follow the ulnar nerve down between the two heads of the FCU to make sure there's no residual entrapment there. And of course, you want to mobilize the joint and watch the nerve to make sure it's stable. And this is my incision. This is one of my cases. You can see the incision is about maybe 3 centimeters long or something like that in this quite muscular patient here. Then I like to test for the immediate return of power. And
okay, now we just released his ulnar nerve.
So if you remember the patient from before,
resist.
This is the same patient.
Here, resist, resist. And now he has power.
And now you can see the power has returned. So the closure is done in a very simple way with a sub-Q 4-0 monocrol suture. I like to use an occlusive dressing. Patient is allowed to shower the next day. Obviously, immediate movement is encouraged. There's no restriction whatsoever as long as the patient doesn't hurt himself or herself. I would encourage nerve gliding exercises immediately. And then I like to apply CCA care on the scar about 3 weeks post-op. Complications of the surgery, just like any surgeries, you can damage nerves. You could potentially fail to release the nerve completely. So make sure you release the FCU, make sure you release the intramuscular septum or Struther's arcade. In particular, if you're going to choose to do a transposition, which I very rarely do, make sure that you're not creating a kink proximally when you're moving the nerve anteriorly. And I have an image of that I'm going to show you in a second. Of course, nerve instability could happen, but quite frankly, it's very rare. And I think if it doesn't exist before your decompression, it won't exist after. This is an example of what happens when you do a transposition. So on the image on the left, you can see what's on top is proximal, what's below is distal, and you can see the nerve has been moved out of the groove on the image on the right, and this is a typical anterior transposition, and you can see that the nerve is now kinked proximally. So that's something that you keep in mind. In particular, if somebody has symptoms after transposition, it could be because of that. Don't forget that, first of all, the prognosis is pretty good, especially if you operate early. Don't wait too long. And just be mindful that there's a number of factors that will influence the recovery potential, like disease, age, and such things. So in conclusion, I like this less invasive procedure because it's less morbid, less complications, less painful, less costly. Satisfaction rate is super high. I love Walant because you can test for the immediate return of power and the patient is convinced that you've done a good job. So they're happy about that, and so am I. And I'd just like to remind one more time that the devil hides in the details and that there's no such thing as a minor surgery. For me, the definition of a minor surgery is a surgery that will be performed on anyone else than me. Thank you very much.
Thank you very much, Jean-Paul. Thank you so much. We have some questions about your lecture and 2 remarks from Dubai. Do you agree that the Osborne arcade is deep and has nothing to do with the FCU fascia? What about the Osborne arcade? What do you think?
The arcade of Osborne?
Yes.
I didn't talk about an arcade. I talked about the ligament.
Yeah. I think
that ligament would. So the question is it separate from what?
From the FCU fascia.
Yes, it is different.
Yeah.
Yes.
Okay.
Yes.
And do you sometimes use JAMA for the strength, to measure the strength? or do you prefer to compare with the power of each finger?
Pre-COVID, I used the JMR preoperatively and postoperatively.
Right.
But now, currently, all my consultations are virtual. People come in on the day of surgery for the surgery to confirm the treatment plan and have the surgery, and then the post-op is virtual also. So it's very difficult for me to follow them with a JMR right now, and I think it's going to be like that for a few months. But it's nice to document it with numbers, and I like numbers, and patients do too.
Okay. And last question about the instability of the ulnar nerve. If there is a pre-op instability, what do you think? Do you make a bigger score to stabilize it and to make and to perform the transposition, or do you try to make a mini-invasive surgery?
It depends if the subluxation is bothering the patient. If not, then I would still do an in situ decompression, and then I would just check what happens. And if there's gross instability and I'm really worried that that's going to cause a problem, then I would do an anterior subcutaneous transposition under Walant.
Okay.
Yes, but that's very, very rare. And if I'm not sure, I would probably leave it alone and just do the in situ decompression, and then address it secondarily if the patient is bothered by the subluxation. Because I think I think the subluxation is not that rare really, but it's rarely a cause of bother to the patient. So if it does not bother the patient, I think it's better to leave it alone. But if it's bothering him, then you'll take him back and do that secondarily.
Okay, thank you very much. I will have a very quick talk about the ultrasound guided carpal tunnel release. I will show you my presentation. Okay, can you see it?
Yes.
Okay, thank you. So this topic is about ultrasound guided carpal tunnel release percutaneously. And why ultrasound guided surgery? Because thanks to the high frequency probe, there is a better resolution and more superficially. So it's very convenient for us to use ultrasound. And now there is validated techniques for CTR, for trigger finger, for tenotomy, etc. I wrote this article, this review about all the techniques and all the organization, and you can read this paper. It's in the French journal, but it's in English. So why do I prefer Walant technique to make a CTR? So Walant is wide awake, though there is no sedative. It's local anesthesia, so you can test the APL before and after the surgery. There is no tourniquet, so no hematoma. Of course, you can use a tourniquet for 5 minutes or 10 minutes, but pain is not the problem here. The problem is when you deflate the tourniquet, you can have an hematoma at the end. Why ultrasound loves Walant? It's because there is no pain under ultrasound and under Walant, and both like movements, there is no side effects, and the patients are participative. And this is very interesting to see the patient check the screen and to check the movement of his or her hand. So for mini-invasive carpal tunnel release, of course, you have the same outcomes, but there is less complication in mini-invasive techniques, less infection and less cutaneous problems. So there is two techniques. There is endoscopic and ultrasound guided CTR. When it's endoscopic, the camera is inside the tunnel, and when it's under ultrasound, the cam is outside of the hand. So what's the difference between ultrasound guided and endoscopic CTR? It's 4 points. There is anatomy of the tunnel, who is discovered at the last moment under endoscopic. And with the ultrasound machine, you can analyze the anatomy before the incision. For the blood, if there is blood of the scope, it's a serious problem, but blood is your friend under ultrasound. So there is no problem to perform ultrasound guided technique without tourniquet. It's about the anatomic variation. There is a lot of anatomic variations in the carpal tunnel, and out of the tunnel, it's not seen under ultrascopic. So it's very useful to use ultrasound to see all the anatomy around the carpal tunnel. And of course, ultrasound is cheaper than a scope if you want to use it in office surgery. So you can explain to your patient what is the problem and why the nerve is crushed. And you can see here the median nerve here, and you can see there is the normal aspect of the nerve and a compression under the ligament here. So you can explain easily. There is the flexor tendons here. You can see the radius and the carp and the carpus. And you can see here there is the problem. And the patient is very happy to see the organic problem. So you can see, of course, median nerve artery. It's not so rare. And you can use the Doppler mode to see here a bifid median nerve here and a median nerve artery here and in this view here. You can have a radial carpal arthritis with the carpal tunnel syndrome. You can see here the median nerve, the flexor tendon, and if you analyze the carpus, you can see here the radial carpal synovitis, which can be a cause of a compression here for the nerve. So maybe in this case, you can use splint to immobilize the wrist, and maybe it's an explanation when sometimes the splint is effective and sometimes it's not effective. You can see also a palmar cyst in the carpal tunnel. Maybe I thought I was a problem of anisotropy here. It's dark and maybe it's the tendon I cannot see. So I push my probe and I push it and I push it, but I can't see anything like that. So there is a median nerve, and this is a very bizarre area into the carpal tunnel. So I open the carpal tunnel and I see a huge cyst into the carpal tunnel. I changed my approach thanks to the ultrasound. You can give information to the patient, and this is a comic I wrote a few years ago to explain that there is a compression here, and after that, with the ultrasound, we can check that the median nerve is happy after the release. So, ultrasound-guided carpal tunnel release under Walant has obviously contraindications. Children, psychiatric patients, an allergy to lidocaine, and you have some precautions like recurrent CTS and anticoagulant drugs, but normally it's okay if you have experience of Walant. If there is anatomic variations, you can change your mind and do an open technique. So this is a video I showed to the patient that we can check all the anatomy, and I draw on the hand where is the median nerve, where is the ulnar artery, and where is the superficial palmar arcade to have a safe zone, a safe area to cut the ligament. So this is a non-pterograph technique with this knife, and we can put the knife into the wrist, and we can check it under ultrasound to cut just stopping before the artery. We can cut the ligament very safely with the ultrasound, and after that we put for the third time the ultrasound on the wrist to check it if it's well opening. So this is a retrograde technique about ultrasound guided surgery, but a percutaneous technique. So we can perform the Walant. It's 20 cc's at the wrist with lidocaine with epinephrine, 45% of saline, and 10% of bicarbonates to buffer the recipe. So we can test the APL, and there is a weakness of the APL before the surgery. This is the one of the tests of the carpal tunnel syndrome. And we can use a high frequency probe. The beta is 15 megahertz. And you take the sterile gel and the cover, and we can use this retrograde hook to put into the carpal tunnel and to cut retrogradely the ligament. So I always use the some draws to place where is the median nerve, the ulnar artery, and I create my safe zone for that patient. It's a customized safe zone here for the median nerve and the superficial artery. So I use a needle, just a needle, to open the carpi volare fascia between the ulnar artery and the median nerve. So this is a 19 gauge needle, and we can cut the carpi volare between the ulnar artery and the median nerve. After that, I make 3 points, you see, 3 points, and I join all the 3 points to make a very small incision finally, but I don't have any scalpel here. So I put like this the hook, and you have to, it's very deep, and you have to get the hook into the carpal tunnel and to check it under ultrasound with a longitudinal view. It's an in-plane check, and you push the hook between the tendons, the flexion tendons, and the ligament. You don't see the median nerve because you are ulnar to the median nerve. So after that, you check where is the position of the hook just before the superficial artery, and you put it, switching the hook to cut the ligament. After that, you can check the section to see if your ligament is open at each level, and you can test the APL after the surgery, and there is the power back to the power back on the table. So that is like the Lacertus, that is like the radial nerve, like the FDP D5 for the ulnar nerve at the elbow. So this is very convenient to check it. I put a small dressing for 24 hours, and after that, it's done because it's a very small scar. So this is in the technical room. It's not an operating room. It's at my office. And at day one, you can check the scar and the flexor tendon gliding. Okay, so thank you very much. Merci beaucoup à tous. And maybe you have some questions. I stopped sharing. And maybe Elisabet and Jean-Paul, did you see some questions?
Yes, I see
we have a few. Go right ahead, JP.
Elisabet.
Yeah, we have a couple of questions for you. One question is, what type of probe do you use?
Okay, so it's a high frequency probe. So my personal probe is Samsung HS40, and it's a 15 megahertz probe.
And JP, what type of probe would you use?
15.
15.
And so I myself, I have a Canon, and for carpal tunnel diagnosis, I use a 22 megahertz probe.
Okay.
But for something like this, I would use an 18.
Okay.
Do
you sometimes use a small probe, or do you find it's convenient to use it?
I must confess, I've never done an ultrasound guided carpal tunnel release. So I use the hockey stick probe for diagnostics and not for the surgery. I still do either mini open CTR or endoscopic.
Okay. And Emmanuel Dudon asked me if I have some tricks to be sure that the canal is completely open. Finally, when it's open, you can touch the ulnar artery and you can touch the medial nerve. So it's not so easy with the hook, because you have to put your hook into the tunnel, and it's not so easy to avoid this very important anatomical structure. So I do it very gently, and I push the hook again, and I'm going inside and outside at each level, inside, outside, and there is my probe like this. So this is the only trick. And after that, I test the APL, and if the APL is okay, if there is strength of the APL, I'm done.
Can I just say something, Thomas? It's the APB and not the APL you're testing. Because...
But it's in France, we cannot do like all the rest of the world.
No,
So,
of course not.
okay, thank you very much, Elisabet. So maybe we'll have for a last question, because it's 5 past 8 p.m.
Yeah, there are a few people who have asked what type of hook do you use? What type of company is it from, and is it found everywhere, do you think?
I have no conflict of interest. This hook is the Extra 2 from Smith & Nephew. It's a very aggressive hook, so be aware to touch it.
Can I just quickly ask a question? Because I've never done this. So I was wondering, did you practice in cadavers before you did it on a patient? Or did you feel confident enough right away?
No, I feel confident because I practice ultrasound guided surgery since 2012. So I do sometimes anterograde technique, and I perform sometimes retrograde technique. So I'm confident with the ultrasound machine, because I have a great experience of that. So
excellent work, Thomas.
Yeah, for the 10th first case, okay, I was a bit afraid of the hook, and now I must confess, you're right. Okay, maybe we can stop it, because it's just a 1-hour webinar. So I would like to thank you, Elisabet, and thank you, Jean-Paul, to be here, and thanks all the people who were here from all that countries. It's amazing to be with us, guys. Thank you very much.
Thomas, how many countries?
63 countries. It's amazing.
So we have
amazing. Thank you very much.
Yeah, thank you very much. Thank you very much.
Thank you, everyone.
And maybe we have to do a third webinar, or it's okay.
Let's see if people want a third one.
Yes. Okay. Okay. Thank you, everyone. And maybe Pachi, are you here?
Yes, I'm here.
Yes. Thank you, Invivox. Thank you very much to organize that.
Thank you very much. Our pleasure to have you with us on InVivox.
Yes.
Fantastic webinar.